Hi, everybody. It's Dr. Linda of the Vascular Birthmarks Foundation. Hi, everybody. Sorry, I'm going to say that again. Hi, everybody. It's Dr. Linda of the Vascular Birthmarks Foundation, welcoming you to our September 2024 Facebook Live with world-renowned expert interventional radiologist from the Lenox Hill Hospital, Dr. Robert Rosen, a longtime expert with VBF for vascular anomalies from the neck down, right? Neck down,
Right.
inside, and out. And we're here today to answer all your questions related to vascular anomalies. Now, give me a second. Would you like to say hello? And by the way, this is our 30th anniversary. How you like
As
that?
if I didn't feel old enough. Thank you.
So let me just check in here to see us. So let me just go back out and come back into our VBF page, because this is where I'll see all your questions. Yep, there we are. All right, everybody, we are now live, and we are ready to take your questions. So just so you know, all right, we've got people already on. Just so you know, Dr. Rosen will be at our super clinic on Saturday, October 5th at the Laser and Skin Surgery Center in New York. Unfortunately, it's the first time in our 30 years we had to close registration yesterday because we have over 200 people coming on Saturday from 8:30 until 1:30, which will probably end up being 3:30. But we have 5 laser teams and 5 consultation teams, so there's 10 teams to handle everybody. But we're really looking forward to seeing you all there, and I'm sure you're looking forward to it. You're always there every year, and it's always a good turnout, right? So I see a lot of you on. Hi, Gina. Hi, Michelle, Maria, Kathy. Hello, Tony. Hi, Tony. Hi, Kiana. Hello from Trinidad. So we're happy to take your questions while I'm waiting for the first one. What's new in the field of interventional radiology with treating vascular anomalies? Is there anything new or anything coming down the pike?
Well, there's, I would say the basic approach hasn't changed that dramatically. You know, it still consists of embolization for high flow lesions and sclerotherapy or direct injection for low flow lesions, venous or lymphatic. And we've had a shift actually in our own practice that we're using more and more bleomycin for the sclerosing as opposed to the STS foam that was kind of the mainstay for a long time.
Was that the Sotradicol?
So, as the foam was Sotradicol, or
Right.
STS was the nickname. And we still use a fair amount, and especially if we need a large volume for a large lesion, we'll probably still go with the foam. But we originally reserved the bleomycin for super sensitive areas around the eye or in the hand or someplace where there was a lot of innervation or potential for toxicity, because it was a much gentler agent and had a quicker recovery and less discomfort. And then we've kind of expanded it more and more.
But you already said it has a quicker recovery and still does the job.
Yeah.
So it's
and the patients comment on how much less discomfort there is afterwards.
And how better the recovery is.
Yeah.
That's wonderful. So I get, maybe you think in the next couple years the bleo will be the mainstay?
Hard to say, because things are changing so frequently in terms of sclerosing agents that I wouldn't predict, but certainly we're probably doing 30 to 40% of our patients now with bleo.
Wow.
So it's taken over a fair amount of the practice.
Awesome.
It's got some potential drawbacks. When it was used for many years as a chemo agent, if you went over a certain lifetime dose, there were
that's
issues
right.
with
I remember
pulmonary
that.
toxicity, but the level of dose that you need to get to approach anything like that is so far below what we're using for these treatments that hasn't been an issue. And peculiarity is the skin sensitivity, which lasts for 48 hours after the bleo treatment, is that makes the skin sensitive to adhesives. So any sticky as EKG leads, bandages, Band-Aids, dressings, we leave it on for 2 days or it leaves a dark mark on the skin. So it's kind of a trivial issue, but something you have to pay attention to those details.
Well, I like those details. So Joe Lewis is saying hi to you from the United Kingdom, and Tony Dolce, Ivana's mom. Hi, Katie from the San Francisco Bay Area. Hello, Francesco. Hi, Judita. Oops, sorry. Oops. Judita Soriente. Hello. I cannot say that word because it's in Russian. But hello from Russia. Michelle Young. Hello, everyone. We are ready to take your questions. Yes, thank you, Gina. Please drop your question in the chat. It is an honor for us to have Dr. Rosen here to be able to answer your questions. He's already told you a little bit about a little shift in his practice. He will be at our super clinic for all of you watching that will be there. He will be there. Hello, Barbara. We have quite a few of you on now, so please start asking your questions. That's why he's here, and you only have an hour. Hi, Michelle. Her granddaughter will be in New York City. Great. She'll be 10 months old and has a full-blown CM AVM covering half her face. Now, you know about these CM AVMs. They're calling these capillary malformation AVMs.
Right.
My comment on that only is that Paula North presented at our conference last year at NYU that there is no such thing, that the cutaneous stain is really an epiphenomenon of the AVM. And I know Dr. Coletti had done some ultrasounds of people who were diagnosed because they had the mutation. They were diagnosed with CM-AVM, and when he did the ultrasound over the birthmark, it wasn't capillary, it was arterial on the flat surface. So
yeah, I mean, some of these things come down to arguments over nomenclature, and some of them actually deal with the basic biology. So I think the understanding is changing continuously with these things.
yeah, the thing that scares me though is when you call it a CM, then they start getting laser, and then they're having, poking the bear.
Yeah. Again, that's not typically part of my practice
I
because
know.
it's more of a
Head and neck.
cutaneous head and neck.
Right. Oh, hi, Benita's on. My daughter was born with a vascular malformation syndrome, Sturge-Weber, and also has hypertrophy of the left arm. At birth, the hypertrophy was so significant she was initially diagnosed with KTS. However, it is not. It is just increased blood flow and muscular tissue on her left arm. Will there be any treatments available to her beyond debulking surgery in the long term?
Again, it's something that's changing rapidly, and typically this kind of overgrowth syndrome isn't a primarily vascular overgrowth in terms of somebody with a high flow AVM may have enlargement, or a venous malformation, or KT may have enlargement. These are really just enlargement of all the tissues. So surgery, if it's that severe, surgery debulking is probably the best way to go.
What do you think about that there with the pros, like these PIC3 CA related, that they're putting them all on the sirolimus?
Yeah, well, it's something that remains to be seen, in my opinion. I think it's clearly an area where there's been a lot of research, and it's certainly promising. In terms of my own personal experience, I haven't been as impressed with the results as I hoped I would be with sirolimus and napelizib and some of these other agents.
I agree. I'm tracking the families, and it seems like the complications aren't worth like during COVID, a lot of them couldn't get access to the sirolimus that they were on, and everything regrew.
Right.
So
well, that's something that's been known about it for a while.
Then you have to be on it for life.
In theory, yeah. So again, I think it's early days for these pharmacologic interventions, and I'm sure in another 5 or 10 years things will be quite a lot different. But
that seems to be the
at
cycle.
At the moment, I don't think a lot of the enthusiasm is warranted.
Agreed. Joe Lewis says, I have a very extensive port wine, 70%, which has been with me for over 5 decades. After being rushed into a few laser test patches 20 years ago, I withdrew. I found it thought-provoking that I wasn't consulted about how I felt. So eventually, my question is whether you have counselors, psychotherapists on your team to help people explore deeply their relationship with their marks. I can answer this.
Yeah, I was going to say that one. Goes to your report.
So we do have Leslie Graff. You know Leslie. She is a child life specialist, and now on our board we have 2, a psychotherapist and a psychologist. And we have every other month we have an AL1 meeting, which is called Adult Living with a Vascular Anomaly, Zoom sessions where you all get together for like group therapy, And then the opposite month, we have PAN, which is Parent Advocacy Network, where all the parents get together with the therapists and discuss the psychosocial implications of living with these. We do have them on hand for our super clinic. That's on October 5th. So 3 of them will be there. So if you do come to our annual event, Joe, which I hope you would come to sometime, you will have access, and a lot of them will make themselves available. So if you want to email me, they can post my email in the chat here, vbfpresident@gmail.com. I can even connect you with one of them if it is something you would like to explore, which is discussing that impact on you. And by the way, lasers have come a long way in the last 20 years. So we have wonderful options.
I would just add one thing to that, and that is, and the people I train in this field, I think it's very important that they're aware of the psychosocial aspects, and especially in childhood. And this is such a long-term relationship that we tend to build with our patients, that the the issues of dealing with them and how they feel, and as they go through early childhood and adolescence and adulthood, we have a relationship that's more than just somebody that technically does procedures. And I think that's important for anybody treating these problems.
Agreed. I mean, you have patients you probably had for over 20 years, right?
30, 40 years.
Really?
Yeah.
I mean, that's what it is with these lesions. It's lifelong management, because right now there's no cure. So it's for most. Hi, Katie. Katie Joaquin says, do you find that sclerotherapy has good results when the patient is not on sirolimus, or better with sirolimus?
Again, you'd find arguments on both sides of this question. We do a lot of sclerotherapy. Most of our patients are not on sirolimus. There are people that are combining it routinely, and I would rather see if we could get a good result with the sclero alone rather than dealing with the drug situation.
Okay. Kelly says, my daughter has multifocal lymphangioma endotheliomatosis with thrombocytopenia. That's actually LMT. Yeah, that's what they call it, LMT. We have attempted lasering a few of the lesions. It was very painful, and we didn't have any success. Do you have any other recommendations?
This might be an area where some of the drug agents would be a worthwhile alternative, and she should probably see either a pediatric hematologist or somebody specializing in these drugs, because it probably would be worth a trial.
I agree. I know that there's a very active group on Facebook that is talking now about a new clinical trial that's coming out for these LMTs, which are very problematic. Thank you, though, for that answer. I see a whole bunch of you. Hi, Kathy. Hi, Zoran. Dr. Barkot from Croatia is on. We'll see you. I think you're coming for the super clinic, right, Zoran? So that'll be great. Yes, Tony, the Parent Advocacy Network, you'll see. Just look at our Facebook page on Facebook, Vascular Birthmarks Foundation, this one right here. Track it, and you'll see when the Parent Advocacy Network meeting is and when the adult. Hey, Susie. Susie is a colleague of mine. She's on. Herod, hello. Bernarda, Brandon. Hi, Kiana. The next VBF PAN session is tomorrow, and I'm hosting it. I forgot. See? So, yes, you can still join us. You can find the link on our page for it. So, thank you, Kiana. You're welcome, Joe. Masa, hello. Is it possible that hemangioma completely disappears with using propranolol? In Slovenia, we call it hemangiol. My daughter is using it from 3 months. She's 10 months. It's on her arm. It's 7 by 11 centimeters. Do you have any prepositions or maybe thoughts about treatment? Laser is not common in Slovenia.
Yeah. No, I mean, I think it's more the rule than the exception that these things will involute or shrink on their own. Obviously, the larger they are, the greater the chance there may be some residual, which may be some either discoloration or some atrophic skin, or skin that's a little wrinkly or pale. And some of that, if it becomes a concern to the patient or the family, can be dealt with plastic surgery. So I would stick with the treatment that you're currently using.
Yeah, we're even seeing a lot of the patients with that involuted and, like you said, irregular skin getting some really good laser with like the CO2 and some of the different ones
To thicken the skin.
to smoothen or whatever it needs. Hi, Marla. She signed up to see you. She said, I can't wait to see you in 3 weeks. It's less than 3 weeks, but we'll see you on October 5th, Marla. Amy Lim, I have a port wine on the right side of my face. Have been dealing with trigeminal neuralgia. My doctors are saying it's not related, but it seems like it is. What is the best way to treat physical pain in a birthmark?
It's not typically combined, those two things, but
No,
I don't
I
know
have
if
not
an
heard of
MR
that.
has been done to see if there's any deeper involvement that may be affecting the nerve function.
Because we do know people with Sturge-Weber have
Right.
neurological
Right.
impact. So, I mean, that might be, you should email me because I can have you talk to our neurologist and maybe she could give you, wherever you live, like, you know, a referral to see someone and to get proper imaging, because if you do have that port wine and that neuralgia, maybe it is some kind of form of Sturge-Weber. It might
Or
be.
deeper involvement.
Or
with the
deeper,
malformation.
yeah, deeper. Okay, we have a long one here from, hi Masa, hi Maria, Nikki, hi, I'm a mama from Oz with a daughter with Sturge-Weber syndrome, all the abnormalities, port wine on half her face, vascular malformations, hope my spelling is correct, had a hemispherectomy for drug-resistant seizures, she's seizure-free now, encephalopathy and hydrocephalus last June, 3 brain surgeries. Life is tough, but we never give up. Just wanted to say hi, and for everyone having a hard time, your doctors are amazing doing these things and doing these lives and giving us some insight. Thank you, just a thank you. Appreciate you all sharing.
Best of
So,
luck.
yeah, and I'm glad that we have these, and she's obviously been on some of the ones I've had with Dr. Comey, who's our Sturge-Weber expert, and, you know, we just bring so much value connecting patients to get an accurate diagnosis and to speak to the right doctor. They say it takes an average of 7 doctors to get an accurate diagnosis in vascular anomalies. And how many of your patients come when it's clearly venous or something like that, and it's all, oh, hemangioma,
Yeah,
right?
I mean, a large part of what we do is patient education. You know, there are some things we could fix quite effectively and some we can't, but at the very least we could usually educate patients and families about the nature of the problem, the natural history, and the best treatments. And yeah,
Great.
it's obviously important.
Hi, Dr. Nasseri. He's just joined us. Good to see you.
Hey, Nye.
Okay, I can't say your name because it's written in a different language, but my son suffers from the syndrome, motor, and mental delay, and he is 3. That, again, may be Sturge-Weber. It's not really like your area of expertise. Hi, Samantha. She's adding to my mom. Oh, Michelle Young. We are very excited to bring my daughter Maya to see you and meet Dr. Rosen. She is currently on trametinib and is working, but minimally. Canada has no more options for her CM-AVM. So we are excited to see what other options will be available. She suffers from regular bleeds and complications, which you hear of a lot,
Right.
right? So she's very happy that they'll be seeing you. Melshi, hi guys, Leo's dad here from Sydney, Australia. Thanks a million for your support. Of course, and always. And hey, we're caught up on questions, so let's go, people. We can take your questions. We've only got like, let's see, well, we're 20 minutes in, so we've got 40 minutes left. This is your opportunity to ask Dr. Rosen questions. You know, he is a specialist in interventional radiology. That is a different form of medical treatment than a neurologist or a surgeon, as most of you know because you're in this world. So he doesn't really treat the Sturge-Weber cases or these cases, right? You're here,
Right.
and then mostly extremities. And there's so many names: venous malformations, lymphatic, arterial venous, PROS, PIC3CA related. There's just so many lymphangioma, the term cystic hygroma. There's just so many different names, and you may not be aware that those are the same lesions that he treats. They just go by different names. So, Leo's, okay, so hi, Tanya, and hi, Reliten. Let us know where you're from, and please feel free to ask a complex syndrome that I treat with physical therapy, and so far he does not sit down. He takes 2 types of epilepsy meds and does not understand anything and is very anxious. Again, that sounds like
neurological
more, yes, and please, we have on our website at birthmark.org, go to Ask an Expert, and you will find Dr. Ann Comey, C-O-M-I. She is our leading and the leading Sturge-Weber syndrome pediatric neurologist in the world. She will be at our clinic along with other experts like Dr. Rosen on October 5th. We're actually doing Sturge-Weber evaluations on the 4th and the 5th because we had 60 patients. So we had to split it into 2 days. But you're welcome to come, or you're welcome to go on our website and talk to her. She can definitely give you some guidance. Can we get a quick definition of interventional radiology and how this specially relates to various birthmarks, diagnosis, and treatment for those that may not know?
All right, well, interventional radiology has now been around probably for almost 50 years, and so it's no longer a new specialty, and it's basically an outgrowth of general radiology, where rather than just interpreting images, people realized that once you could image an organ system, you could also intervene in a minimally invasive way. So that could range anything from a radiologically guided biopsy using ultrasound or CAT scan to angioplasty and stenting for blocked arteries, to treating tumors with different kinds of intervention. And in this area of vascular birthmarks, hemangiomas, high flow AVMs, low flow AVMs, lymphatic malformations, we've kind of been one of the earliest specialists that got involved in both diagnosing and treating these. And surgery used to be the mainstay, if anything was offered. And it still has a role to play, certainly, either in very large malformations or very small ones that can be removed completely, but the bulk of these can be treated using these minimally invasive techniques. So that could involve directly injecting a material into a low flow malformation, or it could be threading a microcatheter into the arteries that are feeding a high flow malformation, and then closing those arteries off using a variety of agents. They could be glues, they could be so-called casting agents like onyx, they could be agents like absolute alcohol, which can be effective but also has fairly high toxicity associated with it. So it's a field that started from a diagnostic field, but now it's really completely separate, both in terms of training and practice. And we do still interpret images, obviously, but the patients come to us for actual treatment.
I have been thrilled at seeing the progression of this area of medicine with preventing a lot of surgeries. Just think of before that, like these people with, even if you have a big focal venous malformation, the only option they had was surgery.
Yeah, and this is true. And all of the field of surgery and every subspecialty has moved to be less and less invasive. It used to be the saying years ago, big surgeon, big incision, and it was kind of this macho thing. And now kind of every field is, whether it's for treating aneurysms in the brain or aneurysms in the abdomen or tumors in various places, people are trying to do the least invasive techniques for treating these. And it's made a very big difference for the patients.
Agreed. Well, we have a lot of questions now that explain that, so thank you for that. How often does the vein vessel that is sclerosed reopen? Can it reopen, or probably means refill?
Yeah, there's 2 separate processes that can happen. One is that the same venous structure that you treated can so-called recanalize, or the clot that's in there can dissolve and the lesion recur. So that would be a recurrence. And then you could have other parts of the malformation that haven't been treated continue to grow, and it may be difficult to tell the difference in any given patient. But recurrence, unfortunately, is common no matter what the treatment is with vascular malformations. So to say that you've cured it, you really need pretty good long-term follow-up. And you also need to differentiate between a clinical cure, meaning that whatever the problem was that brought the patient to you has been addressed and they no longer have pain or swelling or a joint issue or bleeding. But if you did a scan, you may still see some residual, which is not causing a clinical problem. So in my mind, that would be a clinical cure, even if not a radiologic cure.
Yeah, so you're very cautious about using the word cure with these lesions, too.
Yeah, and
They're mostly managed.
Mostly managed, and there's also one thing that I always harp on is that these are not tumors. They can't become tumors. They're very rarely life or limb threatening, and you have to weigh the downside of aggressive treatment versus what you're treating. So if you have a small child that has a malformation, you're not going to do something that has a potentially catastrophic complication to treat a benign, limited condition. So everybody has their own scale of judging risk-benefit relationship, but we tend to be aggressive in treating but conservative in terms of risk management.
It's the way it should be. Tanya is writing to you from Portugal. She has a foot malformation. She's already had 19 operations without a result. The thing is, I've got a lot of pain and all the medication is without result. Can you help me, please?
We'd certainly be happy to try. We would clearly need to see some of your imaging, which I assume you've had. The best imaging is MRI, and you could get my address and send any discs or images that you have. And whether it's a high-flow AVM or a low-flow AVM will determine what the best course of treatment is. If you say you've had 19 surgeries, I'm not sure if you're referring to open surgery or whether you're referring to procedures, but that would be a lot of surgeries. So yeah, I'd be happy to review it and see if we have any suggestions.
Thank you for that. And Gina or whoever is monitoring from VBF, could you please post Dr. Rosen's email address where they can send that information to, unless you want them to send them to somebody else. Do you want them to go to you?
No, that would be something that would currently fall in our area.
Okay. So Katie wants to know, does it only work on blood vessels? My 11-year-old daughter has complicated mixed veno lymphatic malformation of left upper extremity.
No, it's not uncommon to find mixed malformations, especially low-flow malformations where you have lymphatic elements and venous elements. So they don't have to be purely one or the other. One of the clues that there probably is a lymphatic component is a history of infection, cellulitis, fevers, inflammatory changes. Those rarely happen with pure venous malformations, and that usually tells us there's a lymphatic component. And the treatment is also quite similar. It usually consists of sclerotherapy. Some of the same agents are used. Sometimes different agents are used for specific lymphatic malformations.
Thank you. Hi, Michelle. So she said, I think my question was missed. I didn't see it. What is the youngest patient ever treated with electrosclerotherapy with bleomycin for a facial AVM? I know
technique,
Dr. Coletti. Coletti just did a 6-year-old girl.
Yeah.
That's all I know.
Yeah, it's not, that technique currently is not really available in this country, so I would defer to Linda, who's works closely with some of the doctors overseas that are using it.
Yeah,
I wouldn't know what the youngest is.
Yeah, in our pilot study of the ES with Bleo, and Dr. Coletti's study that I'm part of, it's 27 patients, and the youngest one was 6.
6 years old.
6 years old. She had, it was in her jaw and her lower chin area, so it was bone and tissue, and she's, disease-free at this time, based on the last ultrasound. She's
in theory, there shouldn't be any lower age limit for that particular technique, because we treat infants and children, small children, all the time using different kinds of sclero and embolization. So this, in theory, is just a more effective way of doing sclero.
And like you mentioned, it's broadly available like in Italy and some
Mhm.
other European countries, but not yet in our country, not
Correct.
yet FDA
Mhm.
approved. Dinah says, my daughter has an enlarged lower lip due to port wine. Can this be treated with bleomycin, and how is this done?
Again, it depends on who you see and where you go. Some of them are amenable to surgical resection, and some of the plastic surgical results for lip lesions are quite impressive. I mean, really dramatic. And we certainly have a network of people that you could get some names from who do that kind of surgery. They could also be treated with sclerotherapy or possibly electrosclero, and the lip lesions tend to respond fairly well.
We have many head and neck surgeons in our network that have been doing that. And again, it's interesting, since this is 30 years for us, and you've been in this field how long?
45 years?
Wow. So the evolution is unbelievable.
Yeah.
When I started, it was alpha interferon, and then it went to vincristine, and then it went to steroids, and then it went to beta blockers, just for hemangiomas.
Right.
We're not even talking the venous, the lymphatic, any of them. So
Yeah.
it's been crazy.
Yeah,
Crazy
I mean,
good.
the changes, yeah, I would say crazy good for the most part, but I always caution people when every, new technology or new drug comes out with extravagant claims. Some of them do in fact turn out to be miraculous. Some of them turn out to have long-term problems that you don't know for the first few years. So I always urge caution when evaluating early results, and have to give it time, because these are, as I said, young, healthy people with a normal lifespan, so you really have to look at it in terms of long-term results.
Yeah, I wish more people thought that way. Like in the grand scheme of things, you made a statement saying, most of your patients aren't going to die from this. And
Very rarely.
Yeah, and so you really, what is the end point, right? Do they want comfort, or is it a cosmetic for them? Because some of them may have an enlarged limb, and maybe it interferes with the equal size shoes or the kind of slacks they wear, and they don't like it. But again, I guess we think about that, we got to treat this.
Right.
But then it's that long-term sequel that you talk about, like, what is that impact on them? The treatment, and then it's continuous, and once you start, it's continuous. I mean, I guess you could stop, but, and then there's cases that have to be treated, like if it's bleeding, oozing, ulcerated.
No, and those are the situations where you will try every possible approach, including some of the newer experimental drugs, because if all of your normal techniques aren't enough to address the problem, then clearly you have to start looking at different approaches. And also, we don't minimize. Some people say, "Well, is this really causing you pain, or is it just a cosmetic problem?" It's easy to say just a cosmetic problem to another individual, whereas for them it may be a huge element of their life and how they cope in general.
Right.
So it's it's
A
not,
different kind of
It's
pain.
not trivial.
Yeah, you're right, it's not. Hi, Tony. She says, is there a benefit to treating these early if they are not symptomatic? My daughter, age 2.5, has a 3.8 centimeter VM in her cheek, and it's becoming more noticeable with age.
Yeah, I think it's becoming pretty well established that the earlier you treat, the better the long-term result is. And that's true whether it's laser, whether it's sclero. It's easier to kind of get ahead of these things in infancy or early childhood than play catch-up. And especially, there are times that we know that these are going to grow more aggressively. For instance, in female patients, puberty often shows a very dramatic increase in the size or symptoms. Anything with estrogen, including birth control pills, pregnancy. So, yes, I would say the earlier you treat, in general, the better the final result is.
Thank you. So Katie again, she wants to know, and this is a good one for you. I think I might know the answer. Who would you recommend as a pediatric interventional radiologist in the San Francisco area? They're currently going to Stanford. The only one I know is Dr. Kari Nelson. She's in Los Angeles area.
Right.
But she's phenomenal.
Very good. Yeah.
But do you know anyone at San Francisco?
If you give us a week, I'll do some research and we'll find you some names.
Okay, so you can
People
email.
tend to move around some in this field. So
Yeah, so-
I haven't, but people do tend to.
So just email me. My email's in there, vbfpresident@gmail.com. Email me in about a week or so, and I'll nudge Dr. Rosen to see if he has found it, and then we'll get that back to you. But at our free clinic that's coming up on October 5th, Dr. Kari Nelson will be there with Dr. Rosen and Dr. Ricardo Restrepo, who's another very good interventional radiologist in our world of vascular anomalies. So that's what you really want. Most people have to travel. You have patients that come from Europe.
Oh, yeah.
We have states where there are 0 experts in vascular anomalies. So if you have to go to Orange County for Dr. Kari Nelson, you're getting compassion and knowledge and experience, instead of just somebody that might be close. But he'll still look and see if there's somebody close. But I'd like you to really,
I mean, you say it's a strong program. So
Yeah,
there's no
and-
question we could find somebody there.
just as long as they know this stuff. Rhea said, I'm a 42-year-old and mine is growing rapidly. Is there a doctor near Oklahoma City?
What was the lesion? What's going
She
on?
wrote to us before, and I'd have to go back and find out what she said she has. I'm sorry, I can't find it. Just, you'll have to write us back and say what it
We'll follow
was.
up offline.
Yeah, or I can follow up with you. The operations were open stitching, but I've already had alcoholic drying, okay, peripheral nerve blocks without results, and now they're talking about removing the limb. I take 4 types of morphine and the pain doesn't go away. I just want help with medication that doesn't exist in Portugal. That was the one that, so you've got Dr. Rosen's email in there. Before you go any further, get your records together, get an MRI or whatever scanning and imaging to him, and at least let him give you an opinion. We have had cases where we've been able to prevent amputations just by seeing a different expert.
And I would say that the threshold for people recommending amputation is very variable from place to place. And I think in all the years that I've been doing this, aside from the occasional finger or toe or part of a foot, a major limb amputation is quite rare. Probably less than a handful over all these years. And also
Meaning necessary.
necessary.
Not that, but we know people are doing them.
Yeah, I mean, there are some people, and I have people that I've taken care of since they were children, whose even their parents would say, look, they've been dealing with this for 5 years, it's taken over their life, let's just take the leg off and be done with it. And rarely will that actually come to pass. And we could say, no, just hold on, there are techniques you haven't tried. And aside from the fact that some of these very extensive malformations that cross the line, say from the limb to the trunk, whether it's in the arm or leg, technically it's not possible to even do an amputation, or the recurrence rate would be very high, or healing would be almost impossible. So amputation is not the kind of final solution, so to speak, of some of these problems where people have been advised as such.
I can say when we were at a conference in another country, we had seen a before picture of a person with an AVM of the finger, which was treatable, and then
Right.
the next picture, he showed that he'd taken the finger off to solve the problem.
Yeah,
But
and it was
that's,
still blood squirting across the room.
yeah, but again, we know,
Mhm.
like you said, you can go to 3 different countries and get 3 completely different approaches to managing these lesions. That's why we took our team around the world, and you were with us in Russia and India and Israel and Italy and Germany and Greece and Italy twice. She has Sturge Weber, this one woman, and her bottom lip is growing. I'm not sure where you're from, Rhea, but you need a vascular anomalies head and neck surgeon. They're on our website, but if you want to email me directly, tell me where you live, I'll be happy to refer you. Joe is saying, wondering if you have any experience of chimerism, chimerism, chimerism. I have a very distinct straight line. Oh yeah, chimeria, I've heard of that. Down the center of my abdomen. Port wine stain on the left, none on the other. When and how would this have occurred when I was in the womb?
Yeah, I mean, we do see these lesions both in the head and neck and in the trunk, where it's almost like a straight line drawn across the midline. Nobody really knows. There's a lot of research in vascular biology now on all these very complex pathways, and there is a situation called, it's a form of what you're discussing, which is mosaicism, where you actually, if you do genetic analysis of the tissues on one side versus the other side, you'll see that there is a distinct genetic difference, and some of those are approachable with some of these new drug treatments that act at a genetic level. But yeah, that is a pattern that's not that rare.
Okay, thank you for that. We still have 20 minutes left, everybody. Had a lot of really great questions, but we still have 20 minutes left. Now remember, we never delete any of these. We've got them with Dr. Rosen back to 2017. Once a year, we do our Facebook Live together. And if you go to birthmark.org, on the front page, you'll see the little YouTube icon. Click on it. You'll see all of our videos that we've ever done. And you can go back and watch some of the other ones with Dr. Rosen or with some of the other physicians that deal with this specific area. Okay, so Orla Lynch's, my daughter's following MRI and biopsy diagnosed with venous malformation between upper lip and nose, 18 months old, was on propranolol for over a year, as we were told hemangioma. It did nothing, only recently confirmed venous. What are our best treatment options?
I'm sorry, what was the location again?
Venous malformation of the mouth.
Of the mouth. Again, some of these...
Right, upper and lower lip. Right.
Yeah. Some of these can be very well addressed with surgery. Some of the maxillofacial surgeons or plastic surgeons, similar to the way they do cleft lip surgery, can remove these and have an excellent anatomic result. They usually don't respond, and again, I'm not a head and neck laser expert, but they usually don't respond all that well to laser because they're kind of full thickness venous malformations. Propranolol, we wouldn't have expected to work because it's not a hemangioma, but it's commonly a misdiagnosis, especially around the nose and the face, that they're called hemangiomas. So, yeah, you could send us photographs and we could probably get a better idea of where your question should be directed.
Yep. This is a guy, Brian Adam Rusek. Hi, Brian. My birthday was September 14th, and we spent quite a bit of time on the phone, which I enjoyed. But he has a precious little girl, Haley, very extensive vascular involvement in her leg. She's scheduled to see you at the super clinic. They're literally driving from California to here. They don't want to fly with her. She's only 9 weeks old.
Oh.
She's also had some spontaneous bleeding. There's been multiple diagnoses. First they thought KT, but she's RASA1 negative because they thought, oh, this must be CMAVM or Parks-Weber. But wouldn't they have to be RASA1 positive?
Well, some of these are not absolute correlations.
Okay.
And we see a fair number of these patients that we strongly suspect have one of these syndromes, and they get the genetic testing and it comes out negative. So it's not mandatory that you have this clinical presentation with a genetic change.
Yeah, she
Or at
physically...
least one we can identify.
Yeah, I mean, and also what I thought was so unique about this case is he described that when and nothing was picked up on imaging all during pregnancy. Nothing shows up. So this is presented. It's very extensive, multiple locations, even on her lip, her leg, her one toe, the second toe in, looks very vascular, almost like a KHE type of thing. And they wanted to amputate, but I said, no, wait until you come to the super clinic, bring all your records,
Right.
and so you'll be seeing, he's bringing all the imaging, everything with him, so we'll take really good care of you. I already labeled her page, Brian, to see Dr. Rosen and other members of the team, so she's gonna get our blue plate special. Let me leave it at that. But so I want you to hear what he says. Thank you for talking to me. We look forward to meeting you. We've been searching for a diagnosis and plan of attack for our daughter who was born with vascular arterial, they don't know, malformation on her right leg, including a blood-filled bubble on her right knee, which was biopsied, and they literally drained it at birth, I think it was. She also has a bulbous and black toe on her right foot and small lesions throughout her body, including her lower lip. Our genetic testing came back negative for RAS1, and our PIK3CA is still pending from Seattle. We realize that we are just beginning this long medical journey with our new daughter, and we are grateful for finding your foundation just in time for this coming event to get some expert eyes on her. No real questions at this point, just excited to finally have some positivity. I mean, people don't realize what they go through.
No, sure.
You know, you're at birth, you're handed a baby, and we spoke enough, and I had a condo in Dana Point, so I knew they were at this really bougie, high-end hospital, but they never seen this.
Yeah.
So what did they do? They take the baby and the dad and stick them on a helicopter and medvac them up to Chalk because they're scared because they had never seen it.
Right.
Now, she's born at Lenox Hill, they'd have just called you,
Right.
right? They wouldn't have had to medvac the baby. But we are going to take good care of her. So you just know that Haley will be in great hands when you get here, and you'll get great opinions. So we're really looking forward to seeing you. And the baby. Okay, yes, okay, Joe, good, great. I wish there were port wine stain images. Somebody created those. Kiana is our VBF Global Ambassador Director, and I think she was chatting with someone at one time that's creating, or it was somebody like, maybe it was even Chelsea Pete, she creates these port wine stain like emojis for people. So that it is out there. It is out there, Joe. Just got to find the person who does it, and you could even find out from our Global Ambassador Director, Kiana Smith, if that's something she's doing. So we still have 15 minutes. There's 15 minutes left. These have been great questions. Hi, Shannon. Nice to see you. Shannon Snyderman. I'm surprised, like, normally I see a lot of your other families on here saying hi, you know, a lot of them aren't on. It could be because they're working or in school. Okay, that was you today. Okay, Mel said, my son Leo is 3 years old, born with extensive port wine. We live in Brisbane, Australia. Doesn't believe in frequent laser. That's why we drive to Sydney, so that Dr. O'Neill, who is amazing. My question for Professor told us before there will be drug for port wine that may help him. Is that correct? Leo has port wine stain all on his lower legs, his right hand, shoulders, chest, and his back, but not his face.
I'm not aware of any of the current medications that would have a dramatic impact on port wine stains. And
I've never heard that.
Laser on the head and neck can be very effective. Unfortunately, the further away you get from the head and neck, the less dramatic the effect of laser seems to be. Doesn't mean it may not be worth trying for some test areas, but we often see patients that don't respond particularly well to laser in the extremities.
True.
Whereas in the face, it could be a very dramatic response.
One of the people who asked a question before said she's emailed over images, and they are from Ireland. So that's Orla Lynch. So that's great. He or someone
I think I actually
from.
responded to her earlier today.
Oh, great. So there you go, Orla. You remembered, right? The
Yep.
name from
Mhm.
Ireland. You got a good
Yep.
memory. Okay, so we still have now 12 minutes left.
You sound like the home shopping network.
I know,
We should
right?
Get you a job.
Get down to 12 minutes. I don't want any more jobs. This is 30 years of VBF, everybody. So this is our 30th anniversary. And let me give my own shout out while we're down the last 12 minutes here. If VBF has helped you in any way during our 30 years, we're asking you to make a $30 donation. That is literally nothing. It's $1 for every year. We've helped 150,000 people get networked into treatment. So if you go to birthmark.org/donate, we're only asking for $30 from everybody to help us continue with our mission. And that's just such a minor thing. I think it is. I think it's minor. But I know for some of you it's a lot, but I'm doing the ask because I always do. Okay, so thank you very much. There was another, is removal necessary? I've never had my birthmark removed. She was talking about a port wine stain, having it removed. But with port wine stains, you have a laser, and now,
Depends on what part of the body.
well, yes, but the new trend with, and I'm calling it a new
Mhm.
trend in port wine stains is, in the past, for the first 10 years, everybody wanted them gone,
Mhm.
or as much clearance. Now, the newest trend is some just want it.
Mhm.
They don't want the laser, they love it. Or they want just the skin to be healthy, so they just get like one treatment a year just to make
Mhm.
sure it doesn't thicken or develop blebs. But laser is still the gold standard, so, that related to that. She's never had it removed.
And again, as we said, there are situations where surgical removal is not a bad idea.
Right,
If you have a patch of skin that's very abnormal, it's probably never going to be normal, and there's a feasible way for a plastic surgeon to remove it, you get a good closure, there's nothing wrong with that.
right, or overgrowth,
Yeah.
definitely is gonna
Mhm.
need it. Any overgrowth will need it, you're right there. Okay, so we still have some time to take some more questions. Remember Dr. Rosen of the Lenox Hill Hospital in New York City. He is the director of the AVM Center, also been doing vascular anomalies from the neck down of the extremities for over 40 years, you said. And one area that we never talk about is I get a lot of questions of women who have them in the below the belly, and they're pregnant. And they're like, what should we do? Should we go off of our sirolimus, or should we not be on a medication, or should we not get treatment? And I'm sure you get this all the time, like ones that want to have a baby and have it.
It's rare that we advise people not to get pregnant because they have a vascular anomaly. If the exception would be if there's obviously direct involvement of the uterus or some of the pelvic organs could potentially be a problem, and at the very least would require a high-risk OBGYN to be involved. And we have several that we work with who have been doing this for years. And since it's so far out of the realm of most obstetric practice, most OB guys will just say, or girls, women will just say, I have no idea what this is, I don't want to get involved.
Right.
But there are some who are used to it and are not frightened by it.
And thank God for them.
Yeah, and almost all these patients can be managed successfully. There are rare exceptions if for a high flow AVM in the pelvis, that can actually be something dangerous to carry pregnancy because of the increased blood flow and hypercirculation, potential cardiac effects.
Yeah, that's
But
something
it would be unusual.
Since we have these 8 minutes, you just brought something up that I wanted to ask you, which is, at what point does this begin to impact the cardiovascular system, like where they could be in danger of
It's
of
a
it?
common, almost every new patient I see, whether a child or adult, the question will come up, is this going to affect the heart? Is this going to shorten the lifespan? Are they going to go into heart failure? It's a very rare phenomenon. To have a high output cardiac state that could be progress to heart failure is probably something that maybe 1% of vascular malformations could have that risk. Low flow malformations virtually never, because there is no increased circulation, no increased cardiac workload. High flow malformations, they have to either be very large or in a small child to affect the heart to that extent. It's not to say it doesn't happen, but we probably see 1 or 2 patients a year that have cardiovascular effects from an AVM. It's one of the first things that people read about online or are told by a general physician, this could affect your heart. It's actually quite uncommon.
Well, that's really good to know, because I have heard patients say they were told it could.
Yeah.
So it's really just misinformation.
Yeah, and it's not to say it can't happen,
Right.
but it's the vast majority of patients, it wouldn't even be a potential risk.
Thank you for that. So we have 7 minutes left, everybody. I know one new thing that's coming out is the electrosclerotherapy, and you've been interested in this new approach with the device that's not approved here.
Right.
And I know you're closely following it out of interest,
Correct.
cautiously optimistic.
Mm-hmm.
And you have seen some minor results from this, right? Or have seen some
I've certainly
cases.
seen presentations of cases that were quite impressive. And it's a variation on something that we already do, which is sclerotherapy by directly injecting into the malformation. What it adds is a very high rapid pulse of electricity, which there's a lot of theories about why it would work in terms of opening up self-permeability or doing something to the endothelium or the lining of the vascular malformation.
So it really makes the bleomycin a little more effective, actually.
That's the theory.
Mm-hmm.
That's the theory. And again, it's early days, and in terms of permanent results and things like that, you really need a few years track
Yeah.
record before you could say it, but it certainly seems to be promising. And we're following closely for what, when it will become available here.
I'm excited about it, cautiously optimistic and excited. Joe asked again, are the cardiovascular effects, is size of the lesion relevant?
It's relevant in the sense of a high flow malformation. If it's very large, can cause high output cardiac state, and over time could potentially cause high output cardiac failure. This would generally be in most patients, it would either be a very large pelvic high flow AVM, which is something that we see. Again, not failure associated with them, but it's actually a relatively common location for high flow AVMs, is the pelvis, for reasons I don't know why. Occasionally we'll see it in limb lesions, particularly when you have Parks-Weber syndrome, where you have lots of small vessel shunting, and the limb is enlarged, and it's usually very warm to the touch from the high flow. That can occasionally be associated with high output states, but again, these would be exceptional malformations.
I have a question for you. Are you recommending or responding to a lot of requests I'm getting lately for do you think patients should get the genetic testing done before they see you, or does it matter? Or
Again, I'm not a geneticist, and certainly don't. The pathways are now so complex that only geneticists, if they can't even follow all of the most recent developments in these genetic pathways. I certainly don't think somebody needs genetic testing before they come and see somebody including me, for treatment. And it's still questionable, as we discussed a minute ago. The correlation is not one-to-one. It's not as if you have this typical clinical picture, you will have this genetic picture, and it's still not clear how that affects what treatment you should have. There's a theory that if you're positive for certain characteristics, you're more likely to respond to the drug treatment. But again, as we've alluded to, the drug treatments have their pros and cons, including the likelihood of recurrence when you stop the drug. And there's obviously side effects of the drug itself while you're on it. And there's always the unknown of drugs that are relatively new, that you don't know what the effect is going to be 10 years later down the line.
I know the most important thing I learned today from you is a new dialogue I'm going to have, because a lot of doctors are telling the families, if you're RASA1 negative, you don't have an AVM, and you said that is not 100%.
Yeah.
And so they should continue to explore, because a lot of them will use that to get laser, thinking, oh, well, I don't have that, so I can get laser and I'm not going to poke the bear and have a problem. But maybe if clinically and everything else it looks like a high flow lesion, maybe it should be treated as one.
For sure.
Like an AVM.
Yeah, for sure. And it's actually quite uncommon in my experience for high flow AVMs to respond to drug treatment. I'm sure there are isolated cases, but certainly not the rule. And I would just say that if you go online and you look at some of these genetic pathways, they are so unbelievably complicated, and this is
And
all
they keep changing them.
And always changing, and these are only findings that have been available for 5 or 7 years at the longest, and every month new factors come up, new discoveries. So I think we are really scratching the surface when it comes to the molecular biology and the genetics of these things. It's exciting, but to make clinical decisions based on it at this point, I'm not so convinced it's warranted.
Yeah, and we got a perfect example of that in the Sturge-Weber world. The big discovery was the GNAQ. Well, now they have GNAQ 11, GNAQ 13, and who knows what they'll have next. Like you said, it starts out one tree, then 10, and then 10 more
Yeah.
for what before was just one
Right.
mutation. Now it's got like a tree under it.
And I think even people in the field that hear talks on it, you're sort of sitting there with your eyes glazed over after the first 10 minutes because it's just so complicated you can't believe it.
I think Gina says it so well today. She said, "This has been an incredible session with so many insightful questions from the community here. Thank you all." So thank you, Dr. Rosen,
Pleasure.
for an incredible session. And then one last one. Did COVID vaccination potentially cause blood clots and microvessels? Are you seeing any evidence of this or changes in your patients with vascular anomalies?
It's a very good question. I've got 2 or 3 patients that swear that their clinical situation changed dramatically after they had COVID. Certainly on a statistical basis, I don't know that there's much evidence for that, nor can I explain it scientifically. So I don't think so. The vast majority of patients we had were concerned about whether they'd be at risk for blood clots because severe COVID could be associated with clotting, and they knew they had malformations that could be associated with clotting, and they thought the combination of the two would be super dangerous for them, and we really haven't seen that kind of correlation. I have seen patients that symptomatically think they got worse after having COVID. I can't comment whether that's cause and effect.
Good answer. Thank you. And we will see you all. We are not having a Facebook Live in October because of our conference, but come back in November. It is my annual Facebook Live with Dr. Ann Comey, the Sturge-Weber syndrome expert. So stay tuned. Follow us on Facebook. Thank you. Have a wonderful holiday season coming up soon for you. And enjoy this beautiful fall weather. And take care, everyone. Thank you. And we'll see
Thank
you
you.
all soon.